All right, so I'm Dr. Horn. Dr. V couldn't be here today. We're going to go over what should I do with a positive TB test. So as you come in, you'll find that you're on mute, but if you have any questions during the talk, please feel free to unmute yourself and ask any questions that you have. Feel free to interrupt me at any point. And if you have any questions, you can either unmute yourself and ask me a question, or you can type a message in on the chat. So I can see those questions as well, if you'd like to type them in. So we'll go ahead and get started. So in this talk, we're going to talk a little bit about tuberculosis, and we're going to talk about what to do with a positive TB test. We're going to talk about the types of TB tests and talk mostly on TB tests, latent TB, and isolation. We're not going to get into treatment for TB, but this is going to be mainly for what to do with a positive TB test and kind of some considerations when testing patients, who to test, and kind of along that line. So what is Mycobacterium tuberculosis? It's an airborne bacterial infection, usually infects the lungs. It's spread from person to person through the air, most easily in closed spaces over a long period of time. And it's almost always can be treated and cured. So wanted to differentiate tuberculosis, this is Mycobacterium TB, from atypical Mycobacterium. So atypical Mycobacterium, it's found normally in soil and water, and it causes infections in people with weakened immune systems. And this is MAC infections. This is Mycobacterium avium and Mycobacterium intracellulare. These are also acid-fast bacilli. This is AFB. It'll show up as AFB on the stain. And then you have to, usually when it comes up, if you're testing for TB and you have a positive AFB, at that point you're not sure if it's going to be an atypical Mycobacterium or TB. So it's when it comes up, usually the microlab can kind of get very worried that you're going to have TB, and if people hear that they're AFB positive, everyone can get very worried, but you have to kind of wait and then figure out if it's TB or an atypical Mycobacterium. So in a patient that's high risk for TB, you would consider it to be TB, and you'd keep them in isolation and kind of, you want to make sure you isolate them early on if you're concerned about TB. But otherwise, if it's a low-risk patient, you would wait for confirmation to make sure that that it's an atypical Mycobacterium. And these are all over. These are in soil. This is in tap water. So if you take a shower, you're taking a shower in atypical Mycobacterium. Usually, patients that come down with atypical Mycobacterium infections are transplant patients, immunosuppressed patients. Because atypical Mycobacterium is usually not pathogenic, it's considered an opportunistic infection. So patients that are transplant patients, when they take a shower, they're exposing themselves to atypical Mycobacterium, and kind of the water, the mist that's in the air from their shower, when they breathe it in, they're breathing in atypical Mycobacterium, and this is usually not something that we're worried about. Most healthy immune systems can take care of it. So not everyone infected with TB bacteria becomes sick. As a result, two TB-related conditions exist. We have latent TB and TB disease. So usually when we're testing patients with either a tuberculin skin test or a quantiferin, we're seeing if they've been exposed in the past. So a positive PPD and or blood interferon are not used alone to diagnose active TB. So if a patient came in and they had symptoms of active TB, which we'll talk about in a minute, if they're coughing, if they're chronic weight loss, they have night sweats, we wouldn't use a PPD, tuberculin skin test. We wouldn't use that or an interferon gamma release assay to say if they have active disease. So we would essentially treat it like it's active disease. You might do a test on them, but these tests are not how you diagnose active disease. latent TB infection. So this is, latent TB infection is the presence of tuberculosis organisms without signs and symptoms of radiographic or bacteriologic evidence of TB disease. So these are patients that have essentially been exposed in the past. And what I tell patients is that their body's taking care of it. So if they test positive for their PPD test positive, or their quantiferin is positive, and they're at risk of being exposed to TB in the past, we'd say that they have latent TB. And we'd say that you're not considered active TB infection, but at some point in your life, you've been exposed to TB and your body's taking care of it, okay? And you wouldn't worry about them spreading TB. They used to kind of think about it as latent TB or active disease, and now they kind of think about it more as a spectrum. It's not as black and white as they used to think about it before. They used to say latent TB, they have absolutely no symptoms, and they were exposed to it in the past, and that could be the case. But there's also kind of, there are some patients that aren't as black and white, and they kind of on a spectrum. Here's latent TB versus pulmonary TB disease. So latent TB infection, positive TST, this is a tuberculin skin test, or IGRA, this is an interferon gamma release assay result. So latent TB is essentially defined as having a positive test for TB and being exposed to TB in the past, but their body is taking care of it. Their chest x-ray is normal, and they don't have any symptoms. In pulmonary TB, their test, their tuberculin skin test, or IGRA, is usually positive, but not always. And the chest radiograph is usually abnormal. And we usually think of them as having a cavitary lesion in their chest that's essentially full of TB and causing them to be sick. But a person could have pulmonary TB, they could have active TB, and their skin test is negative, or their interferon gamma release assay is negative. And there are kind of two thoughts of why this can be. One thought is that their immune system is overwhelmed, and their immune system is trying to fight the TB that's essentially overwhelming their system, and they're not reacting to it. And the other thought is that the person has an error. They have an issue with their immune system where they're not fighting the TB. And it could be that this is why the TB is essentially causing such disease in this patient, is that their immune system isn't recognizing the TB and isn't fighting it. So those are kind of the thoughts, but if a person has what you think is active TB, if they have a negative tuberculin skin test or have a negative interferon gamma release assay, that wouldn't persuade you that they don't have active TB at the time. So latent TB infection, no symptoms or physical findings suggestive of TB. And if respiratory specimens are taken, then they would be negative. They would be smear negative and culture negative. And the difference between smear and culture negative, so when the AFB is collected, so when sputums are collected, they're collected and then they're looked at for AFB. And when they're looked at immediately, that would be considered smear. That's considered the smear. So if it's smear negative, and then even if it's smear negative, it would also be sent for culture. So it might be smear negative, but culture positive. And if that's the case, and when you think of infectivity, how infectious is this person? It's also on a spectrum. The patient could be coughing up and all of their sputums are smear positive, or they could have 3 smear negatives, but they grow under culture. And that patient would be less likely to be infective because essentially the bacterial load in those sputums is so low that they're not considered as infectious as if they're smear positive. Now, pulmonary TB disease, the symptoms may include, and these are the classic ones that you think about when you're thinking about symptoms for patients with TB. So this is fever, cough, night sweats, weight loss, fatigue, hemoptysis, decreased appetite. These are chronic symptoms that a patient kind of languishes. They have these symptoms for a long time and kind of do poorly over time. Respiratory specimens are usually culture positive and smear positive in about 50% of patients. Now, targeted TB testing. So TB prevention and control strategy, we want to target patients that are high risk of TB and target them and see if we can overcome this kind of TB from spreading from patient to patient. Detects persons with latent TB who would benefit from treatment. And the idea is to treat patients with latent TB so it doesn't come out later in life and so they infect and expose other people. We'll talk more about risks for latent TB coming out and becoming infective. D emphasizes testing of groups that are not at high risk for TB. So some patients can have positive TB tests and then in a low risk patient. And so if you take a patient that's low risk and if you take a population that's low risk and you test everybody, if you have a positive, it's most likely a false positive. So testing low risk groups is not really advisable. You kind of want to target who you should be testing. Now this goes really for any test. If you test a low risk population and you have a positive, it's probably a false positive. So if you test patients for the flu in summertime, that's kind of a low risk, and if you have a positive, it's most likely a false positive. But if you have a flu outbreak and you're testing patients and you get a negative, then it's most likely a false negative, right? So you want to make sure that the population you're testing fits, the reason to be testing them, and it can help reduce the waste of resources and prevent inappropriate treatment. So you want to make sure that the patients you're testing are appropriate to be tested in the first place. And when I see patients, when they come into clinic and they say, I've been told I have latent TB, I'll look and I'll try and ask them, why were you tested in the first place? Because sometimes it kind of makes sense, but sometimes if you look at their exposure history and everything, if they're lacking exposure history, it could be a false positive. But here's this is latent TB versus TB disease. So latent TB, they have a small amount of TB in their body, but it's inactive. Their body's taking care of it. Cannot be spread TB. It cannot be spread to others. So people with latent TB don't have to worry about spreading TB because their body essentially has it under control, and they're not they wouldn't be infecting anyone. They don't feel sick. They feel fine. Usually their TB skin test or blood test is indicating that they've been exposed to TB in the past. The x-rays are normal. Sputum and cultures are negative. Should consider treatment of latent TB. So we'll talk to the patient and we'll say, we recommend treatment so it doesn't come out later in life. And we'll talk more about what kind of reasons they would have for having it come out later in life. But we recommend treatment of latent TB, and essentially later, it could be when they're elderly and they get, they're in a nursing home, that their body becomes weakened and then the TB comes out. It might be that in the future they have a transplant. They might have a transplant and be on immune suppression medications, and then the TB comes out for those reasons later in life. They might be develop cancer and chemotherapy later in life, and these are things that, from my perspective, it's better to treat them early, and so they don't. If you treat them for latent TB, then they wouldn't have to worry about having TB later in life and having it come out and become active and being a health risk to other patients in the nursing home or other patients sometime later in life. So latent TB does not require respiratory isolation, but active TB, they have a large amount of TB. They're spreading it to others. They feel sick, cough, fever, weight loss. Usually their TB skin test, usually it's positive, but maybe negative. X-rays are usually abnormal with a cavitary lesion. Classically, it's a cavitary lesion. They need treatment for TB, and they're considered a case. They're considered a patient that's a TB case, is when they have active disease. And here, this again shows the difference between latent and active disease. So infectiousness, latent TB is not infectious, where active TB is, by coughing and talking. Diagnostics, they have a positive PPD or a positive interferon gamma release assay. Tuberculosis disease. Tuberculosis disease is diagnosed with positive AFB smears. And so if a patient comes in with classic symptoms, you would check their sputum, and You should check it at least 3 times, because checking it, the likelihood that you're going to see it on just one smear is low. So you want to get at least 3, 8 hours apart, and 1 in the morning. And if you get a sputum in the morning, it has, essentially they've been sleeping all night and their sputum builds up. And when they cough it up in the morning, they're more likely to have a positive from a morning sputum. Now, some healthcare facilities will check once daily and all 3 in the morning, and that's fine. But you're also, you could check once every 8 hours and 1 in the morning and take them out of isolation faster and this is depending on how your facility wants to test. Symptoms. So latent TB, they have no symptoms. Tuberculosis, cough, fever, weight loss, night sweats. Isolation. Latent TB, they don't need isolation. TB disease, they need airborne precautions. At least 2 weeks of while they're being treated. Now, not all patients, now if a patient goes home, they can go home with active TB. We'll talk more about isolation a little bit later, but they can go home with active TB. And with active TB, we recommend, well, in cases of active TB, the Department of Health, they have TB nurses that will help give the TB medications, and they call it DOT, directly observed therapy. So each pill for TB the patient takes is directly observed, and they're essentially trying to ensure that the patient takes all their pills and completes their treatment. And treatment of latent TB is to prevent conversion to active TB. And latent TB, they don't need to be treated all the time. We kind of discuss with the patient, and I prefer it's kind of person dependent on each patient, but we discuss the pros and cons of being treated, and really it's as an infectious disease, we recommend that people be treated to prevent coming out later in life. And what is the likelihood that a person with latent TB will have active disease later in life? Usually people talk about 10% or so, but we'll talk about this more in a minute. But it depends on the patient. And this is a spectrum as well. So if a patient is healthy and they have no medical problems, the likelihood of it coming out is extremely low. But if a person smokes cigarettes, they have a little bit higher risk. If they have diabetes, it's a little bit higher risk. And it essentially is a spectrum from smoking from healthy to smoking cigarettes, diabetes, chemotherapy for cancer treatment, and then HIV, and essentially the farthest is probably transplant patients that have undergo a transplant and they're on immune suppressive medications. So I wouldn't think of it as everyone that has latent TB has a 10% risk. It's kind of a spectrum, and it depends on each patient. So we included some factors that predict transmission. This is the susceptibility of the patient, whether they are immunosuppressed or not. The infectiousness of the patient. So is the patient coughing up TB? Exposure. How long were they exposed to the patient that's infected? And clinical factors. Are they coughing? Are they covering their mouth when they cough? Are they wearing a mask? And the anatomical site. So pulmonary TB is very infectious. The most infectious is larynx. It's laryngeal TB. And radiographic evidence. So cavitary versus non-cavitary. Characteristics of patient with TB disease that are associated with infectiousness. So this is presence of cough, respiratory tract disease. They're not protecting their cough when they cough and expose people. The procedure, undergoing cough-inducing or aerosolized generating procedures. So if a patient has a wound with TB, if they go to the operating room and they're undergoing a procedure, some procedures can cause it to be aerosolized and spread up into the room and infect the practitioners performing the procedure. Identifying risk factors that lead to development of TB. So 2 categories: those who have an increased likelihood of exposure and then those who have clinical conditions that increase their risk of progressing. So likelihood of exposure, these are close contacts to people with infectious TB, residents and employees of healthcare facilities, homeless shelters. So these are the type of questions we'll ask the patient. We'll say, you know, do you know anyone with TB? Do you know anyone with a chronic cough that hasn't been diagnosed? Have you ever been to prison? Have you been homeless or working in a homeless shelter? Recent immigrants to TB endemic regions of the world. So have they been living in a place that has high rates of TB? So in travel clinic, patients will say, well, I'm going to a country that has high rates of TB. They'll say, I'm going to go to India, I'm going to go to Nepal, and I'm going to be there for a couple weeks. Should I worry about TB? And the travel books, they kind of say, you know, it depends. It depends what you're going to be doing in this country. If you're going to be doing the typical touristy things, then you wouldn't have to worry about it. If you're going to be working with the homeless people in these countries, then your risk is elevated. But if you're going to be living in a country with high rates of TB, generally they say about 6 months. If you're going to be there about 6 months or more, then you can kind of think more about it. But it's really who you're exposed to and what you're going to be doing, what kind of activities. Person's more likely to progress. These are HIV infected. These are patients with issues with their lungs, with chronic pulmonary conditions. Children less than 5 with a positive skin test. So children are extremely high risk. So with patients, with adult patients, if they're exposed to someone with TB, it's usually pulmonary. They get exposed, that's the classic patient that you'll see in the movies, where they'll be coughing up blood and have chronic weight loss and fevers and chills. Well, children have, when they're exposed to TB, it enters through the lungs, but they usually don't have a cavitary lesion. It will be more likely to be extrapulmonary, meaning that it goes to somewhere else, another site in their body. And it's often thought the patient will come in and they'll think the patient has osteomyelitis, a bone infection somewhere in their body. It might be their leg or their foot, and it's essentially hematogenous spread of the TB that doesn't set up in their lungs. And if it doesn't set up in their lungs and present classically like an adult, then if the patient has a positive skin test, if it's a child, you want to be very aggressive with them and treat them very aggressively so it doesn't go to their bones and destroy their bones, or have essentially miliary TB. So you don't really see children walking around with a chronic cough and coughing up blood, and it's not kind of, but you want to be very aggressive with children. Now, underweight, malnourished people, substance abusers, and those on TNF-alpha antagonists. Now, this is from the New England Journal of Medicine. I wanted to include this because this is also kind of how I think about it, a spectrum. This is incidence of active TB, and this is per 1,000 population. So if you look at now these are different risk factors. Patients on tumor necrosis factor blockers. They'll have patients undergoing hemodialysis. It's extremely high. So they have a weakened immune system, and they're more susceptible to having active TB. So dialysis patients, people with HIV, prisoners, healthcare workers is also an elevated risk. Immigrants from countries with a high tuberculosis burden, and homeless people. So these are all high-risk patients that, when you're thinking of the spectrum of patients to worry about when they complain of TB symptoms, you want to think, well, if they're a dialysis patient, they're at high risk. If they're an HIV patient, that's another high-risk population. So when you're thinking of, how much should I worry about this patient having TB, these are high-risk patients. And testing for TB. So here we have the TB skin test, and we have the interferon gamma release assay. And these don't exclude TB. So even if it's negative, so if a patient has TB symptoms, but they have a negative TB skin test, you wouldn't say, oh, this patient cannot have TB. You'd want to get AFB several sputums, 3 sputums, 8 hours apart, 1 in the morning. Now, skin test, it produces a delayed hypersensitivity reaction in patients with TB. So it determines how many people in a group are infected, contact investigation. So if a person comes and says that they were exposed to someone with TB, so where should you start? So it would be a good idea to do a TB skin test then, and then again in several weeks, in about 4 weeks or so. So if their skin test is positive when they come and see you, then you would test them again in about 4 weeks. And if it goes from a negative to a positive, then that's what you would use to say, that they've been exposed to TB. And examining persons who have symptoms of TB disease. So if a patient comes in and they have symptoms, you would want to get 3 AFB, but you could also do a TB skin test. You wouldn't want to rely too much on it, but if it's positive, that can be helpful. Administering the skin test. So here's some information about administering it. You essentially put it in, and this is an intradermal injection, and it creates a wheal. So here's intradermal injection, it creates a wheal. And then we'll talk about positive in a second here. And when you read it, so you want to measure the reaction in 48 to 72 hours. And you're measuring the induration, not the erythema. So you want to actually do it, when you measure it, you don't just say it's a positive or negative, you want to measure how many millimeters. And you want to use your finger. You want to use your finger at the site and see if you can feel the induration with your finger. So you're not measuring the erythema, you're measuring the induration. And this is important because we've had many patients come to clinic and say, I had a positive skin test, and we'll call the provider or the person that was reading it, and we'll ask about how positive was it. And sometimes people will say, oh, I didn't know I was supposed to measure anything. It was really red, so we considered it a positive. But in those patients then, if we don't really have a clear answer, we might follow it up with a quantiferin test. Now, and we'll talk more about quantiferins in a second, but educate patients and family regarding significance of a positive skin test. Positive skin test reactions can be measured accurately for up to 7 days. Negative reactions can be read accurately for only 72 hours. So this is one of the things that people say is it's a limitation of the skin test, is that the quantiferin test, you can take a sample of blood and run it, and you don't have to see the patient again. So with a skin test, you have to make sure that the patient will follow up. And here's how to interpret the TB skin test. Induration of 5 or more millimeters considered positive, and they have different populations. So a patient with that's either high risk or has a reason for having a low immune system, you'd say greater or equal to 5 millimeters. And here this is measuring from the induration, not the erythema. And these are, so 5 or more, so between 5 and 10 essentially. It's HIV patients, chest radiograph consistent with prior TB, transplant patients. These are patients that either can't mount an immune response and they're high risk. 10 or more. So healthcare workers are considered 10 or more. And these are injection drug users, recent immigrants, and an induration of 15 or more, any person, including persons with known risk factors for TB. So essentially, if it's 15 or more, that'd be any patient. Now, I included this because sometimes we get questions about a two-step skin test. So if a patient came from another country and they could have been exposed many, many years ago, then the thought is that if you do one skin test and they're negative, then 1 to 3 weeks later, if you repeat it, then they might be positive at that time. And so they might need this two-step testing. So they do one skin test and then 1 to 3 weeks later, another skin test. If it's negative, then they probably they've never been exposed to TB. This is kind of one of the things that we think about are the residents. When medical residents come from other countries, as an intern, they might be tested and have a negative, but then the next year when they're tested, they have a positive. So to try to overcome this, I mean, it could be that in the country that they came from, they were exposed when they were young, and then the first time they have a test, it's negative, but then the second time is positive. So they would be considered, if you didn't do a two-step, you'd consider them a new conversion and say that sometime during their intern year, they must have been exposed to a patient with TB. Interferon gamma release assays. So there are two. There's the quantiferin. This is the quantiferin gold or a T-spot. And this is a blood test. It measures and compares the amount of interferon gamma released by blood cells in response to antigens. So it entails mixing blood samples with antigens from tuberculosis and controls. So cells recognize the antigen release interferon gamma, and the amount of interferon released in response to tuberculosis antigens is compared to in response to other antigens, essentially placebo. And so the interferon gamma release assay will give a number, and above about 0.35 would be considered positive. Now, this requires a single patient visit, so this is why a person might consider doing an interferon gamma release assay. They could see it now, and then the patient wouldn't have to follow up. Results can be available within 24 hours. It does not boost responses measured by a subsequent test, and prior BCG vaccination does not cause false positive. Now, this used to be a bigger worry, this false positive BCG. Now, the recommendation is that even if a patient had BCG when they were younger, to essentially ignore it if they have a positive TB skin test. You'd ignore it and you would consider them to have latent TB, and you'd treat them anyway. Now, the disadvantages of interferon gamma release assay. The errors in collecting and transporting the blood or interpreting the assay can decrease the accuracy. So there have been some, actually quite a lot of false positives interferon gamma release assays. Limited data on the use of interferon gamma release assay to predict who will progress to TB in the future. So can't really use it to say, you know, because it gives you a range. If it were extremely high, you can't use that to say that there are higher likelihood of having it come out and become active. And now I will say with interferon gamma release assays, some things that can cause false positives. So there's Mycobacterium kansasii that's in this area, and it's named after Kansas, Kansasii. So that's something that can cause a false positive interferon gamma release assay. So if someone had a history of just exposure to Mycobacterium kansasii, could cause a false positive. Mycobacterium marinum is another thing that can cause a false positive. So, and marinum would be from the sea. So if we've seen patients that have had they either go swimming in the ocean and come down with a Mycobacterium marinum infection, or they have collect lobster traps or something like that, and they cut themselves and expose themselves, and then they will test positive. Now, anytime someone tests positive with a TB skin test, if they're positive, our recommendation is always to never have another TB skin test. And the reason is because they will always react to it. And in the future, if they have repeated tests or they're tested again, they might have a reaction it can cause some necrosis and skin necrosis there and cause scarring. So we would always recommend, once they're positive with a TB skin test, not repeating it, never having it repeated again. Now, selecting a test. So IGRAs are preferred method testing for groups of people who have poor rates of returning. So if the patient isn't going to come back, patients who have received BCG vaccine, this is the skin test is preferred method for children under 5. Yeah, so before initiating treatment for latent TB, and routine testing with skin testing and IGRAs is not recommended. So doing both of them. So sometimes people will say, my patient has a positive TB skin test, should I do an interferon gamma release assay, quantiferin gold, and check it? And then if that's negative, then I won't have to treat the patient. Now, it's not recommended. That's really not how it's supposed to be used. It's tempting, because it's tempting because you'd say, well, the interferon gamma release assay is really supposed to be more specific. It's supposed to not have as many false positives. But that really hasn't been the case. There have been quite a few false positives with interferon gamma release assays as well. So, I would just recommend go ahead and if they tested positive with one, just go ahead and treat them. The treatment is very well tolerated, and then it will kind of this question of, could TB come out later in life? They wouldn't have to worry about that. Evaluation of persons with positive TB test results. So this is a person has a positive test for TB, and then the first question is, do they have active TB? Do they have symptoms that would say that they have an active TB at the time they're infected, could be infecting people? Consider for latent TB treatment. Now, the person accepts and is able to receive treatment. So some patients will say, well, I don't think I have that, or I'm not going to take treatment for that. And this is something to discuss with the patient. Develop a plan of treatment with the patient to ensure adherence. If the patient refuses or is unable, then follow up with a skin test or IGRA and serial chest radiographs. It's unnecessary. We'd really recommend, if they have a positive skin test, it's really symptom-based. So if they start having fevers, if they start having a cough, anything concerning for TB, that's when you'd want to do it, more so than yearly chest x-rays. Some facilities will do yearly chest x-rays. It's really kind of probably easier for the patient to go off symptoms-based. So for every patient, assess the TB risk factors. If the risk is present, perform a test. If it's positive, rule out positive disease, or even before performing the test, consider whether they have active symptoms. If TB is ruled out, initiate treatment for latent TB. And if treatment is initiated, ensure completion. So treatment regimens, I just wanted to touch on it. We generally do isoniazid for 9 months. Now, I think the World Health Organization says 6 months is enough. But there was a time when the US was having more of an issue with TB and outbreaks. And if you look at the difference between treating for 6 months versus treating for 9 months, the additional 3 months actually helps with some patients. Now, 6 months, you get the majority of the benefit from isoniazid, but as you continue to treat, if you look at the graph, you'll include more people and you'll get rid of it in more people if you go for 9 months. So the United States, essentially the CDC says to treat for 9 months, and the World Health Organization says 6 months, and that's the majority of the benefit. So we'll do 9 months. Isoniazid is essentially one pill once daily. And now these other regimens we don't usually do unless the patient can't really tolerate isoniazid. So if they can't tolerate isoniazid, we've moved to rifampin. Now, when do you isolate? So if a patient has known TB disease, you'd want to isolate them. So you'd put them in respiratory negative pressure room. Positive AFB smear for tuberculosis from sputum or culture from the lungs. They're symptomatic. Ruling out active TB. So if a patient comes in and you're not sure if they have active disease or not, but if they come in, they have the classic symptoms, they have a cavitary lesion, you would put them in a negative pressure room until you're sure that they don't have active TB and they're not spreading it to other healthcare workers and to other patients. So order for a chest X-ray to look for any signs of anything abnormal in their chest X-ray. Order for 3 AFB smears to rule out TB disease, and ask, are we ruling out active TB? So when in doubt, ask the other providers and see what the plan is and everything. Now, as far as masks go, the healthcare worker should have essentially a N95 mask, and the patient can wear a surgical mask. So if the patient is going to go get an X-ray or going, for a procedure, the patient should be wearing a surgical mask, and everyone that interacts with the patient should have, a N95 mask. When to no longer isolate. So 2 weeks or longer of adequate therapy and improvement of symptoms, and 3 consecutive negative sputum AFB smears. So once they have 3 consecutive negative sputums, then you wouldn't need to isolate them. And these are things that when the patient, some of the patients will go home and the Department of Health, the nurse will go to their house, do directly observed therapy, and the nurse will collect the sputums. So if a patient is actually doing okay, it's okay for them to go home, and essentially we'd recommend staying in their house and not exposing people. And if they go out in public, which we recommend not doing, we recommend for them to wear just a regular surgical mask. Now, special consideration, so aerosolizing procedures. So this is, we've had several patients that have TB wounds, and with these TB wounds, if they're going to do a procedure that will aerosolize it and put it up into the air, then it's important for everyone to, airborne precautions, N95 masks. This is a PAPR, this is a positive air pressure respirator. This is something that, if someone has a beard or they can't wear an N95 mask, then they're supposed to wear a positive air pressure respirator where they put a mask over their head, and it has a fan with a tube with a fan, and it pushes and positive pressure, so the air is flowing out of the mask, so no air flows into the mask. And with that, wanted to touch on some of the important topics with TB. If you have any questions, I'm available for questions. If you'd like to unmute yourself and ask any questions, or type any questions, would be great. So, as far as Nebraska, we've had kind of an increase in TB recently, and trying to get it under control. Now, in the past, they used to say, if a patient's in a nursing home, if they had a positive TB skin test or a positive interferon gamma release assay, they would say, there used to be an age cutoff. And they would say, oh, you're 92 years old. We don't recommend treatment for latent TB because you're an elderly patient. But actually, it's tolerated very well. Isoniazid, many patients take isoniazid without any problems. And so now there's no longer an age cutoff. They would say, even if you're 92 years old and you have a latent positive test for latent TB, they recommend treatment. And the goal is kind of for that patient, but it's also a health risk. So we wouldn't want that patient having active TB in the nursing home. So, and I think that in general, the primary care providers and the general practitioners might talk to somebody with latent TB and say, you were exposed and your body's taking care of it. I don't recommend being treated. I think infectious disease providers kind of have a lower threshold to treat them, because in the future, if they were to have chemotherapy or have any kind of be put on medications, really for arthritis or Crohn's disease or anything that weakens the immune system, it could come out and cause a real health problem. So I think ID people are kind of have a lower threshold to treat. But all right. Well, if there aren't any questions, thank you very much for tuning in. And I think that if you have any questions, please go ahead and email me, and we'd love to go over any topics that you'd like. All right. Thank you very much. Have a good day.